is you can see the head of the humerus, not very clear, I'm sorry. You can see tendon, that would be infraspinatus tendon. You can see deltoid muscle, you can see the bursa. That represents 1 millimetre. So you can appreciate the bursa, even when it's effused, is only about 2 millimetres thick. And the only way you can be certain that the needle is in the bursa is actually doing the technique under ultrasound guidance. And what you can be certain of is you can see that what you're depositing is going into the bursal tissue, not into the tendon, not into the deltoid. But we only do the injection if the patient has gone through that process of relative rest and if they're not allergic or there's no contraindications to having a period of ibuprofen. Now, there are 2 reasons we will use steroid in the injection. There is evidence for the use of steroid. There's no evidence for any inflammation in the tendon. There is some evidence from research done in Finland that in some patients who've got constant pain and night pain, there is evidence for bursal inflammation, for bursitis. So there's no evidence for tendinitis, but there is limited evidence in some patients for bursitis. And that's one reason we are prepared to use steroid in this injection. The other reason we can rationalise and we can justify using steroid in the bursa is that in the tendon, if you remember the picture I showed you before, there is an increase in the number of tendon cells. There is an increase in the number of tenocytes, fibroblasts. And what glucocorticoids, what the steroid can do, what the glucocorticoids can do, probably by osmosis, is steroids can also reduce fibroblast populations. So an added advantage of glucocorticoids, of steroids, is it can reduce fibroblast numbers. So again, you wouldn't want to introduce steroid into the shoulder in someone who's got partial thickness tearing and someone who's got full thickness tearing, because their tendon will have a reduced fibroblast population, and you wouldn't want to reduce it any further. So the only time we would do a steroid injection into the shoulder is when the patient has got this reactivity in their tendon. 1, to try and reduce bursal inflammation, and 2, to try and reduce fibroblast populations in the tendon. When our patients have injections, and when you start doing injections in Norway, I would strongly recommend that you do not allow the patient to go back to work for a few weeks. They have to keep on moving, but they've got to stop doing any fast activity. So we get our patients to sign a consent that for 4 or 5 days they will not drive, they will not do any heavy lifting, carrying, pushing or pulling for 2 weeks, and no fast activities for around about 3 weeks. Whether they do that or not, I don't know. But we try and explain to them the importance of continued relative rest after the injection in order to maximise its benefit. And our results have been very good.